All right, great. All right, so next up, we have the pleasure of hearing from Dr. Berenstein. He's professor of neurosurgery, radiology, and pediatrics here at Mount Sinai. He's co-director of the Pediatric Cerebrovascular Disorders Program. And you may not all know that he began his career at Mount Sinai. He did his surgical internship here in 1972-73, and then he did his radiology residency here as well. And while he was a resident, he actually performed the first embolization in New York City, which was a gastric aneurysm embolization. He then went on to a career in which he has been innovating constantly for the entire career. And some of the most basic foundational tools that we use are his invention. For example, the Berenstein catheter, which is a catheter with an angulation at the tip that allows us to perform selective angiography and select which vessels we're going to go into. And it is very fitting then that now he is working on another project that is potentially going to form another basic foundational tool that we use, the Bendit catheter. And so really looking forward to hearing from you, Dr. Berenstein. And thank you so much.
Alex, if you're talking, we don't hear you. Can you hear me?
We might have to work on audio for a second. We're in the same room here, so 1 second.
Can you hear me now?
Yes.
Can you hear me now?
Yes.
Okay. Thank you, Chris. See, when you start, you get Chris as a fellow. Then when you finish, you become Chris Fellow on the computer. So what I'm going to present you, this is my interest. I am a board member of Bendit and chief medical officer, and I'm an investor. We just got published this new concept in neurovascular navigation, but I will show you, I think there is more to it. The technology is 2 laser cut hypotubes that permit you to mobilize in a 3-dimensional way. Imagine the nose of an elephant. So we can actually be able to manipulate, and we can use it with or without guide wires. The device comes with a, the video go, yes. Okay, so you have a handle that permits the bending or articulation of the tip of the microcatheter, and then as you let the button off, it will stop exactly at that position. You can then torque it, micro torque it for fine positioning, or macro torque it by actually turning it with a 1-to-1 torquing capabilities. Even if there is tortuous anatomy, the ability to actually torque and the ability to articulate is maintained, as you can see here. So you can still torque on a 1-to-1, you can still deflect the device. It permits you, or you may use it alone, or you can use it with up to 0.18 guide wires. So you can actually point to the location, and then even with the guide wire, you still have a 1-to-1 ability to torque, a 1-to-1 ability to deflect. Things that we found also is we can manipulate. Here is the Bendit inside a soft intermediate catheter. In this case, it's called the Sophia, for example, and we can bring the Bendit within 2 or 3 millimeters of the tip. and we can now make this catheter bend. So this is a non-shaped catheter. We can actually now bend it and torque it, and we can actually engage, for example, the carotid artery, and then advance the soft catheter, keeping the bended as a scaffold. So that actually, imagine, is like increasing the nose. And permits you to navigate and enter distal parts. And I'll show you some examples of that. The first work we did was in rabbits, and here is a bifurcation aneurysm. And what we see here is the ability to, if you just advance the catheter, it goes into the aneurysm. So now by torquing and bending the catheter, we can selectively catheterize the right carotid artery. Then we can come back, and we can now bend the catheter and point and catheterize the left carotid artery. And again, notice there is no guide wire here. We're able to do it. This acts both like the catheter and like the guide wire. We can do things like, for example, go to 2 o'clock in the aneurysm. We can go to 11 o'clock. We can go to the middle of the aneurysm. We can go to the neck of the aneurysm. So now we got a tool that we can, inside a vascular space, we can actually manipulate it, versus what we have today, which is you can't do anything. It's got a shape, which usually you lose. Now, for example, here, placing a coil in the dome of the aneurysm, the coils have a memory, so they're gonna do what they're gonna do. And this is what we can do. We can put, for example, something at one position and something else in another position. So now, if you were to put a coil in this aneurysm, this is how a regular coil will behave. It will go to the walls of the aneurysm, and then what we call, it will break, and therefore it will then hug itself against different parts. So this is how a regular coil would behave. And you can see it goes down to the bottom of the aneurysm, it goes up. So I have no control over the way of the coil deposition. With the Bendit technology, what we're gonna do is get the same coil, and now we're gonna take the coil and just put it in the dome. We don't want anything at the bottom. So by manipulating the torque, we're gonna put the whole coil just in the top of the aneurysm. So we have now a new way to manipulate things inside a vascular space. So you can see how we can, by finding the right angulation, right position, is deliver all that coil just into one position. And of course, we can develop now devices that can use this, this advantage. Now we're gonna do something else. We have the coil is being placed in the aneurysm. Okay, sorry, it did not advance. Okay, you can see now that inside an aneurysm, we can actually turn it around so that we can have a new type of devices that could be placed into a location. Oh, I'm sorry, I went. What happened? Okay. Sorry. Okay, yes. So here we have put the coil. Now we're gonna take the Bendit and we're gonna try to trap that coil and bring it down. So here we have the manipulation. We go inside, and then rotate. We try to grab the coil, and you see that we bring it down. And now we're gonna take the coil and push it up, push it back into the dome of the aneurysm. So we have now a tool that can actually manipulate. Now you can imagine if you had two of them. This I show you. And now here we have a braided stent has been placed on the right carotid. And now we're gonna go with the Bendit without a guide wire. We can actually inject contrast material as we advance. And we're gonna either go inside the aneurysm, but we wanna go in to the left carotid to do a wide stenting. So here you can see the device as it goes, crosses the stent. Look, hardly there's any movement to the stent, and we can advance into the left carotid. And this is a very small 2 millimeters aneurysm. And this, for the most part, is difficult to catheterize because you need to put a guide wire to it. And here you will see the manipulation of the device getting into a 2 millimeter aneurysm without a guide wire, getting into the aneurysm selectively. And now we're going to put a coil. And another advantage of this technique, because you don't need a guide wire, is that even if the catheter or the coil comes out, the catheter is out, we can reposition it. And then as we continue the coiling, this is a control angiogram that shows there's still some space. And here Dr. Killer is putting another coil into the space. And by just gentle manipulation, you can find the spaces. You will see the catheter comes out, we bring it back in. The coil goes out, bring it back. And now the whole catheter and coil will be out of the aneurysm, Normally, you would have to bring the coil back and recatheterize the aneurysm. With this technology, we can just go back into the aneurysm and continue the packing of the aneurysm. And we were able to have this thing repeated by 3 different physicians. And this is the final control angiogram that we obtained in this animal. Now we can also go and rotate. Here we did it for the FDA. So we're rotating around the circumference 3 times, and we have histology showing that there's no damage whatsoever. So what I'm showing you is we may have new kind of stents that we can just put a small stent just at the hole of the aneurysm, for example, because now we have the technology to manipulate and check. And this is, you see no spasm, control angiogram after. And here we had, this was a surgically created aneurysm, and one of the stitches obviously almost completely closed the right carotid artery. So here you see the Bendit, no guide wire. You can see as we go through the stenosis, we inject contrast material, we see that we are intraluminal. And then here is a guide wire was placed, and here's a regular Duo 21 trying to cross the lesion, which already was crossed by the Bendit. And you will see that the stenosis was quite severe. Is this moving? Yes. Okay, and you'll see we take the excess of the wire, we'll bring the catheter. So here is a conventional catheter trying to cross the stenosis. And you can see it's so tight, you can see how it's bending, and you can't get the device or the catheter go in. So put more wire. So we put more wire in, and it just kept on taking us. So we had to re-dilate it with the Bendit, and then we're able to come in. But you can see that even that doesn't permit to come in as compared to how easy it was to go in with the Bendit. Here is after we put a stent into this location and reopen the artery. Here is a sidewall aneurysms catheterized again with the catheter without a guide wire. You see how easy it is to enter the aneurysm. And the importance here is to put an intrasaccular web. All of you who know is that the web cannot be used on sidewall aneurysms because the stiffness of the device will kick out the aneurysm. And you can see the stability here as we're delivering an intrasaccular device. So here is the web being placed in position. You can angulate it. You can put it. I'll show you a human now how this works. And here's the control angiogram of that placement. So what are the advantages? No need for a guide wire. If you need a wire, you can use it. You can inject as you travel. So no need for roadmap, but of course you can use it. Can use roadmap or not. It is soft in the neutral position for tracking, but it's very stable in the bend up position, that is to deliver devices. Access from the puncture site to the target destination in stroke, so you don't need exchange guide wires and exchange maneuvers. It supports multi-axial telescoping. precise position of the catheter tip using the torquing and deflection characteristics. So this is a new concept of navigability. We can put coils and other devices in selective places, and then we can just change them. I have to change positions. Catheter can, we can withdraw coils, we can push them in. It permits you to intentionally move the coils, bails you for something like a migrated coil, we can retrieve it back. So Bendit was reintroduced to the aneurysm, bend, and help push the coils to a specific target. So let me show you, this is one of our first human cases, chest wall metastasis for catheterization of this vessel. So here is a Berenstein, regular Berenstein catheter there. And now we're gonna go with the Bendit, and this is Dr. Robert Rosen in Lenox Hill. And look how he's navigating by injecting contrast. It's a new way to do things, and he's catheterizing the different area to deliver chemotherapeutic agents at different locations. So you can see how the device can rotate, can advance, can move, and there is no, it's very atraumatic, the tip, so we don't see spasm. We had one case with a liver with Dr. Patel with a little bit of spasm, but no dissections and things like that. So now the catheter is brought back, and we're going to try to catheterize a more proximal position. And here you see coming more proximal and then coming in selectively to that branch. And now we wanted, the catheter would have gone to this branch automatically. So we come back. Okay, it didn't come. Okay, so this is the experience with the in the animal. So now I will show you the experience that we have with the clinical experience. Okay, we have submitted this paper. It has been accepted for publication on the clinical experience. We've done now 25 neuro cases done in Germany, Austria, and Israel and United States. Here is the device. On your right is catheterization of the vertebral artery. On your left, you see the movement of the catheter as it navigates the different curves of the vertebral. And once you go into the straight part, you reduce. You see this is put in the neutral position, which makes the catheter very soft and permits distal navigation. And here we have the navigation of the passing the ophthalmic artery. Here is the catheter bend, and now we're going to turn it or torque it and bypass the ophthalmic artery to go and advance farther. And now we're going to go into the anterior cerebral artery. You see how easy it was to get into the A1 segment. This is Dr. Chapeau. They lost a stent, and they tried to enter the stent here with conventional technique, and he was not able to. So here we have, he's trying to go now just with the Bendit. So he's going between the vessel wall and the lumen of the stent, and he, in this case, had to use a guide wire. So here is the same. You can see how he's navigating without the guide wire, but now there's a guide wire. And with the guide wire, he's able to advance. The stability of the Bendit in this flex position permits you to advance. Here's the guide wire going in through the lumen of the stent, going into the distal vertebral. That permitted, now you take the Bendit and then you torque it in that Bendit position. And that permits you to pass that, near total occlusion that was there. This was the second case that René did with the Bendit. And you can see how it's advancing. And now here's the guide wire. Now you can see the Bendit going up. Here is the Bendit coming. And then it was used to do an exchange guide wire. And then a second stent was placed. Here is a case done in Tel Aviv as one of the first strokes, MCA occlusion. And here is the video that was taken from the thing as Dr. is coming from the femoral puncture, comes coaxially, triaxially, I should say. So here you can see the Bendit coming up through the carotid artery. going in the petrous carotid and advancing into the intracranial. So this video was taken by the engineer that was watching the procedure. So you can see going up the petrous, and now you bend. There, the bend. Now you torque. And pass, it's how you pass each of the curves. And of course, you could use a guide wire. So it's you're not forced to do it this way, but so you can see how it bypasses the ophthalmic, which, okay. So this was all done without a guide wire. And then here he put a catch mini. And here's the catch mini. And here is after the thrombectomy. So this is the first case done with stroke from the groin. This is Dr. John Barr. This aneurysm was attempted by 2 different teams, and they couldn't find the distal carotid artery. The angle is very sharp. The only way he was able to cross was with a magic, but then he couldn't do anything. So here is the actually the crossing. They did the night before. We did a biomerics model for John to learn. And then you see the tip of the Bendit, and now it's pointing in the aneurysm. And now by bending, we're going to be pointing towards the distal carotid artery. And then a guide wire will be advanced. And the guide wire crosses gets into the carotid artery. Now you need to advance that guide wire all the way to the MCA, M2, M3. And that is for support. We learned from the biomerics model that we needed an 18 wire to have enough support to get the Bendit to cross. So you can see again, the stability of the Bendit permit the advancement of the wire in this pretty tortuous anatomy. When you look at it, it feels like it's a long time, but it's less than a minute. Okay, so there goes the MCA catheter. And then here's the Bendit goes up, and then he used an exchange guide wire and put a flow diverter in this area. This is the first human done in Israel, and this is a difficult right PCA. Twice was attempted, was not possible to do. So with a compassionate use permit, you can see here the Bendit pointing towards the PCA on the right. Once you get the guide wire, you take the excess, and to see the stability of the Bendit permitting the guide wire to advance very distally. Now you would put the Bendit in the neutral position, you relax it there, and now become very, very soft, like a regular conventional catheter. And now you can torque, and track it up into the distal PCA. And this is an ACOM aneurysm done by Monica Killer in Austria. And this is fascinating because here is a contour device, and you can see the contour device producing some change in the flow, but it's not producing enough stagnation. So here you have the Bendit can be used to fine tune. So here is the contour, and you can turn it a little bit this, a little bit that way. And the idea is to find the better position so that it can produce maximum flow diversion. So after placing it in different positions, here you can see in this position, look at the stagnation of contrast material within that aneurysm. It's the same aneurysm, it's the same contour, it's just slight different angulation. So this would tell us in the future, but the fascinating thing is this aneurysm was closed in the acute stage. We didn't have to wait time. And this is René Chapeau doing a transvenous approach to this cortex, to this dural AV fistula. And there are 2 veins. This is one, and this is the more anterior veins. And here is the actual navigation of the Bendit to point down to that vein, the second vein. And when he points to it, when he's seeing it biplane, so he can see what the medial location of the vein. And with that, he now can advance the guide wire, and that wire now goes into the vein and you can stabilize everything to permit to advance the guide wire. And then doing an exchange, you can have a microcatheter then be placed all the way deep into the dural fistula to treat it transvenous. So this is, for you, some of you, this is one of the most difficult things is to catheterize a cortical vein because of the angulation, and they're very narrow as they enter the sinus. So here is the more anterior vein being catheterized in lateral and AP position. So we did 25 cases and you can see that actually the results were quite well. We failed in 2 cases out of 25 to reach the desired axis. We had 1 coil that got stuck, and the reason is that the catheter is 21 thousandths of inner diameter, and the coil was 14. So by the 3rd coil, the coil plugged the catheter. But otherwise, it's done very well. So I think, how am I doing with time? Perfect. Okay, so I just tried to show you a little bit of this new technology. And the good news is that starting July 1st, we have it here at Mount Sinai. We are the first hospital in the United States. Now that this has an FDA approval, there will be different sizes. We will use a 17, which will be better for aneurysms. And there will be also a peripheral catheter. Thank you very much for your attention. And if there's any questions, please.
Exciting. When did you first have this idea?
Well, actually, the idea was an engineer called Oz Kabiri, but I discovered him. He didn't know what to do with the technology. So when I saw him, he was very, very cumbersome. It's been about 8.5 years.
Yeah, that's wonderful. And it looks very practical.
Yeah. Well, you know, we have now proof in humans that it does work.
You know, I would like to have that exact same mechanism on tools that I use on transnasal surgeries.
Well, actually, Oz come from the GI tract. You know, they did endoscopy. He didn't. I will introduce you. He's a brilliant. He's going to be in New York, actually, at the end of this week. So I can introduce you to him if you want.
Yeah, you know, that is a very difficult problem that we face, is needing that intralesional or intra-space navigation.
Yeah.
Because up until now, we can only navigate from outside to change our viewpoint and so on.
Good idea. I think also for when they're doing bone, injection of acrylics and cements into the bone, I think you could also point down or point up.
Is that going to come in much larger sizes?
Making it bigger is easier.
Yeah, I would think so.
I mean, it's a small company, so it's very hard. You can't just make a lot of samples. But I think that it's a very good idea. I'll introduce you. He's actually fascinating individual too. In general, I mean, he's very smart.
Okay.
We have a question from a few people here. Trevor?
Hi, Dr. Berenstein. Thank you so much. That was an awesome talk. Very cool device. I just had one question. Would there be any utility for a multifocal bend such that if you have the main bend that you've been showing, did they ever trial like even another separate bend at a certain different iteration?
Absolutely. Look what I have. I have my wrist, and I have my elbow, and I have my shoulder. Yes, the answer is yes. There's even more. Right now, you saw just one device. Yeah. But think about it if you have 2 devices, or 2 hands, or 2 fingers. Again, it's a small company. You have to go in stages. But I envision that we're going to be doing a lot of suturing, because you can actually come with a Bendit we have already and can actually have a stitch and then have another Bendit catch it to do. That's the future. That's going to be more in cardiac because they're bigger spaces. But today, every single thing we put, valves, stents, is usually hugging. That's why nitinol is so good, because nitinol you can compress, is an elastic metal, and when you release it, it expands. So the stent, when it expands, it fixes itself against the wall, okay? So can you imagine if we can do intravascular suturing? It will revolutionize completely. And the other one is robotics. You know, the robotics are having not such a good time. But with the robotics, I think this technology will be very compatible.
Thank you, sir.
Thank you.
Adam?
Yes, thank you, Dr. Berenstein. This is really a fascinating technology. I think we can't count the number of times in which navigation would have been optimized by technology like that, navigating through giant aneurysms or making it across vessels that have ledges that are just unpassable by the current technology. I think this will definitely revolutionize what we do. So I'm looking forward to trying it. I think we're having a flow model experimentation with it in a couple of weeks. So thank you so much.
Thank you.
Berenstein, can you elaborate on how this would facilitate robotics? You know, I can imagine doing a 3D spin and then having the computer have that spin in an ideal track down the center of the vessel, and then navigating that, attempting to navigate that.
Okay, I actually have but I have to find it. The way navigation now with the robot is, what the robotics does is it takes the adapter, the Y adapter that we use, and then it turns the Y adapter. That's how it's doing it. And then if you have a guide wire plus a catheter, or if you have a triaxial, the robotics is not that efficient. So first, if you take away the need for a guide wire, you already reduce the problem by 50%. Or let's say you need guide wires in 25% of the time. You will need guide wires. But now the handle of the Bendit is actually ideal for the way the robotic works. And if you notice, there is a little knob in the most distal part of the handle. That is for micro, that you can do half a degree turn. The big movements, you do them like the robotic does it now. So now we have the ability to do 1 or 2 millimeters. So I envision that you will have, today we do 3Ds, you have all the information and you translate. You have Brain Lab, you're doing many things with the digital information. So I think that this is gonna be quite compatible. There is serious discussions now. Problem is that Corinthians, very slow, and for me, they are too slow, but we're trying to work with them. There are 2 other robotic companies that are much more dynamic, but that's how I envision. I think it's going to help. The question is robotic in general. How far is it going to go? That's a completely different discussion, but I think it will have some impact with time. I think we're getting a robotic in Mount Sinai West, correct?
Yeah, should be ready to go in the end of the summer, I think.
Well, I hope we get one in the animal lab too.
Yeah, that would be exciting to try it together. On July 1st, on July 1st, we're gonna have the flow model with the Bendit catheters, probably at Mount Sinai Hospital. So if anyone wants to try it in the flow model, I'm setting it up for that day, Friday, July 1st.
And then we need cases for the next week because we're going to have all the engineers here.
Are we able to use the catheter now, or does it have to be used in the study?
Yes. It's FDA approval. They have the production is difficult, so they have limited production. So the idea is to take 10 centers in the United States, with us being number 1. Once we complete 10 to 15 cases, again, we're being very cautious because it's got to be, well-selected cases and so on. And then we'll go to another. I got a lot of requests from a lot of colleagues that have very difficult aneurysms because they've seen John Barr's and the paper just came out. So we're going to do it on a case-per-case basis. But Sinai will have it. It's all everything. Joanna is the PI here, and it's all under control, or seems to be under control. All we need is cases from you guys. Stroke cases will be great too, Difficult arches will be great too.
Great.
Yeah, fascinating technology, Dr. Berenstein. So what is the current available length of the device and sizes that we have? Which has a clear...
It's 165. There's only one size, but the present time is a 21,000 internal diameter, is a 3.4 French. So if you can deliver any like Webs 17 and the smaller sizes of the Web 21, you can put the stent retrievers through it. So you can go into a stroke. You have the Sophia out for suction, but you can actually put a stent retriever through the Bendit.
Or potentially, if we can just put a Bendit inside the Zoom 88, you can go directly from groin up to the clotted M1 in less than 10 minutes. That would be very, very helpful.
That's the goal. That's the idea. That's the hope.
Hopefully that starting July 1, when we get them in stock, we can do some stroke cases and try that. I have a question. There is a 27 that's available for peripheral use, right?
Right, but it's too short and it's not being manufactured. 21 is where the effort is, and the next one will be the 17. And the 17 is also designed for radial because you need a longer, softer portion of the catheter.
Okay.
Sorry.
Very exciting.
Okay. Thank you very much.
All right. Thanks, everyone.
Thanks, everyone.
All right. Thanks, everyone. Have a great day.
Thank you, Chris, for lending me your office and bail me out with my computer.